prepared to talk about the first face-to-face meeting in about 2 years' time. It is face-to-face, and the audience is fairly small. Slight understatement, and I won't tell you how many people are actually listening live here. So I hope we will have significant numbers somewhere sitting on a computer at home or wherever you are right now. So just a few introductory words before we go into the proper program. If I can move my slides. So the theme of the day is essentially co-production. It's people participation in mental health care. And you will see that this is not only featuring in ELFT's revised strategy paper as one of the core, what's labeled here as organization treasures people participation, but it's also an evidence-based approach, which you will hopefully take away as one of the take-home messages today. It is essentially also featuring as a core unique selling point in our medical education teaching sets. So just to give you a quick kind of sort of run through our USPs, you will see in red highlighted the people participation, co-production, anything focused on the emphasis on subjectively defined recovery goals is what we are trying to bring to our teaching sets. And that is not only in terms of a theoretical theme, but also increasingly in terms of the teaching methodologies we are using. We have now at Trust Headquarters a experiential learning center, and Paul Binfield, our Director of People Participation, together with a number of colleagues, are in the process of setting up a lived experience hub academy. We will see what it's going to be called. And that means that we're increasingly using lived experience in all our training sets, simulation trainings with service user actors. We've done a lot of work with the Playing on Theatre company to do some perspective taking in healthcare. The Human Library project is one of those on our list to be added to the learning sets. And some of you may have come across the A Mile in My Shoes initiative. So having said that, and still only talking obviously to a limited audience, I was wondering if in the 3 minutes really of my prelude, we get a full lecture theater, which is, I can tell you, not the case right now. But I would like to introduce our first speaker, Stefan Krieber, who is a psychologist and a psychiatrist by background. He is a professor of social and community psychiatry at Queen Mary University. And I found him also now listed on Wikipedia, where it says that his research group in social psychiatry has published over 600 peer-reviewed scientific papers. That's probably still an underestimation. Stefan was crucially involved for many years in the shaping of mental health service developments in East London as a non-executive director and the R&D director of the Trust. And the social paradigm and the focus on subjective quality of life have always been at the heart of his research work. And it resulted, among many other applied findings from his research, in developing the Dialog scale and the Dialog plus engagement and therapeutic support tool, which he is going to talk about now. Thank you, Stefan.
Yeah, thank you very much. I've presented a few thousand times, I think, but this is a new experience. In a way, it reminds one of these world conferences when you are scheduled in a seminar at 5 p.m. in room 37B with 5 other speakers and 2 people who are looking for a quiet room to work on their emails. So in that respect, it is well known, but there's a camera. I don't know how many people watch us. I hope we will entertain you. So Dialog and Dialog Plus. I'm very grateful for the opportunity to talk about that, if I managed, yeah. To talk about that, because although both Dialog and Dialog Plus have been used in the Trust for a while, in 2016, the Trust was already shortlisted for the best clinical impact research or so with Dialog Plus, but still there is a lot of misunderstanding. And whenever I get involved in discussions, I realize that it hasn't filtered through what it really is, at least not to everyone. So now everything you need to know, or you may want to know about Dialog, Dialog Plus in one brief presentation. Dialog is a scale, only a scale, nothing more, of 11 items assessing subjective quality of life, and treatment satisfaction. So the scale has now been recommended for national use for all adult services, I think, and it's widely used in London and elsewhere. Dialog Plus, the plus is crucial. It's much more than that. It's a full therapeutic intervention, incorporating and utilizing the dialogue scale, but an intervention. Let's start with the scale. It consists of 11 satisfaction questions, 8 on subjective quality of life, 3 on treatment satisfaction. And each of these questions is responded to on a scale from 1, totally dissatisfied, to totally satisfied. That's what it looks like. So how satisfied are you with your mental health? With additional need, please ignore at this moment. Physical health, job situation, accommodation, leisure activities, partner, family, friendship, personal safety are quality of life. Medication, practical help, and meetings and treatment are treatment satisfaction. Why is these 11 and not others? Because we have found in extensive research that these questions allow patients to raise any concern that's important to them. So for instance, you would see there's no separate question on finances, although it's important to many of us. But we have found that this will be mentioned when it is about job, because maybe patients don't have any, or leisure activities because they can't afford any, or wherever. So this was a criterion that this would allow all concerns to be raised that patients may have. Now I need to go to traditional scales. All other scales that you know, brief psychiatric rating scale, Hamilton rating scale for depression, back depression, inventory, other quality of life scales, well-being scales, all of them are based on psychological test theory. And that means they measure something that is behind it. They measure a construct. So, and the items are selected to contribute to that overall score. So for instance, I blush more often than other people. That item contributes to neuroticism. Whether you really blush more than other people, totally irrelevant. You can't interpret it, but people you say yes, score higher on neuroticism. So these scales produce one overall numerical score, and by definition, the items cannot be interpreted. But the score, 17, 41, 23.5, has no meaning. So you then require very clever psychologists and statistical procedures to demonstrate validity so that the score actually means something and the relevance. So they establish what is a minimally clinically meaningful difference. Do 3 points, is that relevant or is that just too small? So you need all those questions and all that procedures. Dialogue is completely different. Because here, every single item is meaningful and relevant. It documents relevant behavior. So such as when Real Madrid wins against Liverpool 1-0, they didn't test who is better. Nobody needs to ask, is it really valid to score or should we play again? No, this is the result. It documents relevant behavior. When you have an election, nobody says, oh, they voted Tories. Is that really their interest? That's relevant behavior. It's documented, it counts. When someone says, I'm satisfied with that and that aspect of my life, that's important. Of course, it is possible that a patient said, can't you see how satisfied I am? And in reality, they are maybe disgruntled. But basically, that's how in ordinary life, we take statements. We say, are you happy with that? Yes, okay. The consequence is that it produces 2 global scores, yes, for quality of life and on treatment aspects, but it also produces 11 meaningful, relevant, and actionable satisfaction scores. And I will go into that after the next few slides. That was good luck, that despite being developed differently, it has excellent quality. So distributions and all that is very good. So quality of life items are based on the Manchester Short Assessment of Quality of Life anyway, which has been used in more than 1,000 publications. It is well distributed in different populations, different cultures, and it is sensitive to change, to different treatments, and also to diagnostic groups. It's user-friendly, it's very brief, 11 questions. Research says that if you want to ask patients regularly questions, never more than 18. Why 18 exactly, I don't know, but that seems to be a rule of thumb. 11 is below that. It combines the advantage of a visual analog scale and of a Likert rating scale. And I won't go into the details here, but we developed it with a lot of money from the European Union and National Health Institute for Health Research. But even on the color of the bars, we spent separate focus groups. So every single aspect has been well developed. Every single item is a real question, as you may use it in a clinical encounter. In a clinical, how satisfied are you with your family now? Is medication okay? All those questions you would ask anyway. That avoids survey fatigue because patients realize very quickly, if you do it correctly, that these questions matter and are not just there to produce a score for managers. All scores are transparent and straightforward to patients themselves. They know what a 1 is and what a 7 is, and 4 is a neutral 1 in the middle. That's obvious. But it's also straightforward to anyone else who wants to use the scores. And each score can be used to plan, target, and evaluate specific actions, and now the point, for individual patients, for clinicians, for teams, and also for organizations. I said it's relevant for diagnostic groups. Here is just to show the importance of the profiles. We have got the total score of people with major depression with psychosis. And we can see on the left-hand side, people with depression are less satisfied overall. We know that, that's the same in all scales in the world. Whatever is self-rated, people with depression tend to have a poorer rating. And that applies to job situation, physical health, mental health, leisure, accommodation. But it doesn't apply to everything. So the cognitive triad that we've learned, that people with depression see everything negative, themselves, the world, and the future, it's not totally true. So their family and their friendships, they see even more positively than other patients. This is interesting for academics, but it's also relevant for services because it tells you first what to target with different diagnostic groups, but also what you can tap into, where the strengths are, where the resources are. Now, this is more than 5,000 patients in East London from routine assessments. Job situation is typically something that in East London people are not very happy with. And you see that the treatment satisfaction is rather high, but the cross-section data don't tell you very much. This, however, does. This are the changes over time. So, and you can see that overall satisfaction with life improves, good, but there are interesting specific differences. For instance, at the beginning, you see that patients are less satisfied with their mental health, blue, than with their physical health, here colored red. You would expect that in a mental health service. But after a while, this turns around. And people in our services, the mental health service, are actually less satisfied with their physical health than with their mental health. Now, I think to some of you, this will not come as a surprise because too often we say, physical health and GP, and patients never arrive at the GP, and the communication doesn't work very well anyway. But this can have consequences on an organization level because you can think about how to improve the care for physical health throughout from initial assessments to CPAs. This is the treatment satisfaction. Also improving, nice. So it's not an initial honeymoon that patients like us and then find out how disappointing we are. No, they get more satisfied, mostly with the meetings with us, with the clinicians, less with medication. It plateaus after a while, and that is a typical pattern that with medication, patients are less satisfied. So this is only short term, so even in 3 weeks, you can see these changes. And so here, even with a small group, only 150 patients, statistically significant and in the right direction. So patients in a crisis house do improve in their quality of life. Summary of Dialog, before I come to Dialog Plus. It's well tested, it's user-friendly, it's transparent. It provides a score for quality of life and for treatment satisfaction. However, it also provides 11 ratings with important life domains and treatment aspects, that can be used for detailed evaluation and specific planning. And so if you use it with an individual patient, I'll come to that in a second, but if you use it in a team or even on a trust board, it allows a new type of patient-centered evaluation and of targeted interventions. It's actually actionable. You can decide, it's not just, oh, patients are unhappy with this, that is really, I'm really sad to hear that. And then you don't know what to do. So it allows at least the planning of some actions. However, now Dialog Plus, that is completely different. Dialog Plus starts with the context that worldwide, every day, millions of patients have routine meetings with us, with mental health professionals. And these routine meetings are used for conversation, monitoring of symptoms, prescriptions, and referrals to specialized teams. But before Dialog Plus was designed, there was never a specific concept to turn our everyday meetings with patients into something therapeutic effective that would induce change. We could have used concepts from a different context. So we could have asked, oh, similar problems already between your mother and your father, so like a bit of psychoanalysis, or CBT, oh, how did you arrive at the idea that they're after you and that nobody likes you? But that's from a different context, and CBT is hardly effective at all, but squeezed into 5 minutes, there's no evidence whatsoever that it can make a difference. So a radical change was required to make your and our routine meetings with patients therapeutically effective in themselves. We use the dialogue scale that you already know at the beginning of a meeting and hoped that if patient and clinician would see that they would talk about that and already discuss the areas of problems. We did a randomized control trial, and yes, with more than 500 patients with psychosis, only used 4 times over 1 year, it did improve quality of life, but the effect size was small. And it was probably small because we didn't equip clinicians with a guide about what to do. So if a patient said, look, with my partner, it's absolutely terrible, I've heard that 3 times already, I'm really sorry to hear that. And that's it, or my accommodation is so shitty, you can't really stay there. Yeah. Next problem, please. Yeah, so we didn't, and Dialog Plus was then meant to equip clinicians with a guide about what to do. Based on quality of life research, on concepts of patient-centered communication, IT developments, and a lot of solution-focused therapy, we arrived then at Dialog Plus. So you already know this. You go through this, how satisfied are you with your mental health? And after each question, do you need more help in this area? The point of that is that it slows down, because otherwise the danger is that it is filled in within 8 seconds, and it doesn't allow patients to pause for a second. I can go into how long it takes afterwards anyway. So you go through them. After that, you already have something that is very, very valuable. You've got an overview. And if you did such an overview for your life, I did for my life, that would be helpful. It would be interesting to see, okay, partner, family is brilliant, medication, job situation, not. So where am I in my life? Where are my good areas and where are my problems? And then you can compare it with any previous rating. Last month, 6 months ago, 2 years ago. So you look where I have so partner, family, brilliant, and has improved, while job situation has deteriorated. Medication has always been bad. And only once you have done that, you decide, what do I want to talk, the patient decides, what do I want to talk about today? Never more than 3 areas. Usually they only take between 1 and 2. It's usually the areas they're unhappy with, but it could be the areas they're very happy with. For instance, here, partner, family. I've just found a new girlfriend and I'm so happy and over the moon, but I'm a bit concerned that she might want children and I don't, and that come up, and I would like to discuss that. Yeah, so it could be areas that I actually seen as positive, but normally it's the areas that patients are unhappy with. And in case you forget what I'm saying, it's all on a video that's almost synchronized with my current presentation on the Trust website. If you don't have a comparison, you need to decide without that, what do I want to talk about today? And then each area, each concern of the patient is addressed in a 4-step approach. This 4-step approach is by no means a cookbook. It's not that it prescribes exactly how you need to word things, but it gives you a guide about how to move forward. So first is Weiser's rating, and the lower one. I now use a medication example, although you may already have heard that. So medication was a 2 in this case, and has been a 2 for a while. Why am I unhappy? Because I'm tired all day. I can't do anything. The side effects are really unbearable. But then why is rating not a lower one? Because you rated a 2, it's not a 1. And even if it was a 1, you still managed to come here. So something is still working. What's still working? Okay, I've been out of hospital for 9 months. That's for the first time. Oh, that's at least good. And the voices, they haven't gone, but they are much less than they used to be. Okay. Step 2, looking forward. That's for those of you who have ever done a solution-focused therapy training, that's very much a solution-focused idea. What's the best case scenario? In this case, pretty easy, as it would be probably for most of us. Best case scenario for me is to be without any pills. I don't want to think about medication. I want to live without medication and without the side effects and all that. Okay, that's something important to keep in mind. But with most patients, nothing that we can achieve within a month. So what's the smallest improvement? In this case, that takes you from a 2 to a 3, still dissatisfied, but not as dissatisfied as today. So what would it make a bit better? A bit better would be if I at least wouldn't fall asleep during the day. So if I could stay up so that it would be realistic to do some work or do some structured activities. Good. Next thing. Considering options. So what can you do? Now, I could make sure that I always take my medication at 7 p.m. So that I sleep off most of the side effects and are not troubled during the day too much. Okay, what can I do? If I'm a psychiatrist, and I can try and prescribe a bit less. If I'm not a psychiatrist, I can ask the psychiatrist to prescribe a bit less. Worth trying. What can others do? There's a person I live with, particularly after lunch when I'm the most tired, they could take me out for a walk, or if it's raining, they maybe do a board game with me, so that there's something to do that keeps me out of bed. All right, all pretty mundane, small steps, but all realistic. And then you agree on actions. And once you have agreed on actions, you put them down and you review them at the next time. Now I come to the time. Normally, when you do only one area, and you are used to that, even if the patient's not, but you know how to deal with that. In my experience, it doesn't take much more than 10, 12 minutes. I mean, you will always have patients who sit over the dialogue scale and say, oh, is it really 4 or 5 today? Oh, that's difficult to say. I mean, you will always have that. But normally, particularly after the second or third time, when patients are used to the 2, it is relatively quick. Okay, we use that again in randomized controlled trials, this time cluster randomized. I will not bore you with that, but what I will explain is that we compared it with an active control. So one group did Dialog plus, and the other group also had a shiny new iPad, also new technology, but at the end of the sessions, they rated how satisfied they were with everything. So it couldn't influence the meeting anymore, but all the rest was the same. And for those of you who are psychologists and know the Hawthorne effect that rating itself can sometimes lead to improved ratings, all that was controlled for. We did an intervention for only 6 months and assessed outcomes at baseline, 3 months, 6 months, and 12 months. Quality of life was significantly better already after 3 months and still after 12. The effect size was at least as large as for CBT, and that you must let that sink in. Yeah. So if you discuss with the patient that they should have psychological treatment, they accept that, they go there, they arrive there, they stay there for the sessions or attend enough, And the psychologist spends their, I don't know how many sessions they do these days. What is it, 8, 12, whatever. All that does not have a stronger effect than this harmless intervention that you can do yourself within your routine meeting. We also had lower levels of general symptoms throughout. After a year, a better objective social situation. So people were more likely to live independently, to have work, to have a partner. And I'm a social psychiatrist. I'm not aware of any other intervention that has achieved that. And if all that wasn't enough, it wasn't just cost effective, it saved costs. So it is cheaper doing it than not doing it. Some experiences, patient experience, the questions made me look and reflect on my life. I'd never addressed some of the issues that I came across here. Or you start improving yourself because you are aware of it now. It made me realize what I needed to do. Or it was more structured, more professional, more focused, constructive things were being done about certain issues. It's a clinical experience. It was structured. It was easy for them also to follow what we are talking about. I got so much more information out of him. I found it the most empowering tool in 10 years I've been qualified as a clinician by far. It definitely changed our therapeutic relationship. By the end, really, he was very, very much in control of his own care. Good. When as a researcher you do a study like that, most of my trials have been negative. So when you find something in there, that's celebration, champagne, but you still wonder why. You know, and it's such a simple intervention. How is it possible that it can have such a dramatic effect? We don't know, but there are a few explanations. One is it addresses patient concerns. So we can train ourselves until we're blue in the face to be patient concerned. Whether that changes our behavior, we don't know. This makes us patient concerned, patient focused. It will be addressed, and even better, when you take out the tablet or whatever it is, then patients know my concerns will be addressed. There's no, at the end, covered everything. Are you sure? Is that yeah? Has been covered. I forgot to say that we usually use a tablet. Why? Because a tablet can look at that. You can pass it to and fro, but you can also put it away. That's different from looking at the screen when both are looking there and looking at the screen instead of each other. It supports problem solving. You don't get stuck with what's wrong with the family. And many of our patients have been through that 100 times already. It goes forward. It helps with communication. Although communication is the center of what we do, we are not well trained. We are not well trained in communication. We are not supervised in communication. We are not even, nobody even videotapes our communication. But for that, you need to invite me again when I talk about communication. But the basic line is that this helps us to overcome the difficult situation. One group that likes this approach are some GPs, not because of the effect, but because it overcomes their own helplessness. So a patient comes again and says, oh, my partner, and oh, this heart thing, oh, okay, best case scenario, smaller step, you know what to do. You can disentangle and overcome your own helplessness with that set of a patient. And finally, it empowers patients. In SLAM, there was a research showing that in a normal CPA, 8% of the actions are for patients. 92 are for you and me and social work and everyone else. Here, 65% of the actions are for patients. And in my philosophy, that makes real sense because we can persuade, seduce, cajole, bully patients into doing what we think are good for them. Only they can go out and make friends. Only they can take activities. It's their life, it's in them. We don't operate on that. So it's empowering. All these, maybe all of the explanations apply to some extent. Implementation. So you have got here in one step, an assessment, in planning, in intervention, in evaluation, in one procedure. So assessment with the dialogue scale, the planning, your actions, the intervention, 4-step approach, and the evaluation, if you repeat the assessment. It has clear core principles. It has deliberately a very brief manual, because after training, I don't want people to go home and say, oh, that's complicated, very clever. And I don't want to create what people or the literature describes as a compliance culture. So manuals like this, and then you feel, oh, that's not easy. Here, it should be simple and clear, and it has a flexibility in sessions. You can't say at the beginning if you have very little time, sorry, today only one area. However, it has been developed in extensive research and needs to be done properly. I mean, some of you have witnesses that also in East London, some very clever commissioners who have never seen a patient, let alone done research, felt they know much better what questions should be in and changed it and all that. That, of course, is nonsense. If you do it properly. It's simple enough. Please don't fiddle around with it. It has been implemented and tested in studies in more than 18 countries. We've got 8 trials. All of them have some significant benefits for patients. It's also not common. Normally, you've got some trials either way. Not all of them show good results. There is, in the trust, there's a real replication of it, which is so-so. There's a progressive web application that everyone can use. It's free source. Everyone can use it on all platforms, on all operating systems. There's a manual. The whole thing has been translated into more than 15 languages. There's an hearing scale. There's background information. There are publications. All that is on this website. But I would also like to encourage you here in the room and you behind the camera. If you have a good question, please write to me. I get many questions anyway, but I prefer to respond on myself and do it properly than having too much Chinese whisper, because I've heard criticism of Dialog Plus of people who clearly were not instructed properly about what it is. So let's have shortcut communication as much as we can. And with that, I thank you for your attention.
Thank you very much, Stefan. We have actually 3 minutes for a few questions. I suppose I noted simple and clear, pretty mundane, harmless intervention, but still powerful effect. So I guess that is a challenge for those who go to medical school for 6 years and train psychiatry for another 6 years, or go through psychology specific trainings and have very specific skills. So that's my first question to you. Where do we sit with our professional skills in relation to Dialog Plus?
Okay, when we train people, my concern was that people with very little training would be grateful that finally they have got some therapeutic skills, whilst clinical psychologists would be the big rivals. And it was exactly the other way around. So skills do not any harm. So clinical psychologists, I don't know, anyone here? No, so I can claim that without being challenged.
There's probably some virtue.
Yeah. But by and large, clinical psychologists liked it a lot, whilst people with little training often felt in the NHS, oh, life is complicated enough. I have to do so many things already, and now another demand on me here to do that. So I don't think skills are a hindrance.
Any questions in the audience? Please.
I wonder if there were any patient groups that you found it particularly effective or less effective with?
No, I mean, it was originally developed for psychotic patients just because we needed to start somewhere. But as you could see, it's totally generic. So it has now been successfully tested with people also with depression, a large scale, so with anxiety disorders, and in long-term care as well as in acute care. But of course, the how you would exactly use it is a bit different. So in acute care, it's a crisis home. It's more about the planning, that you want to achieve something quickly. Yeah, I mean, the WHO in some areas want to use it for disasters, for emergencies, not emergency A&E, but so that you very quickly get an overview of what, So I think to me, it's more an approach. It's not an intervention, 8 sessions Dialog Plus. It's an approach. And the head therapist in the trust once was very keen that if it is implemented, it should never stop. Whether it's then every 2 months, every 3 or 4, irrelevant, but it's never stop. So that's a patient-centered approach, always stays.
We've got a couple of questions here in the chat box, Stefan. Thank you. Where did this strategy come from? It reminds me of coaching.
It didn't come from coaching. It came from, as I said, a lot of quality of life research and a lot of solution-focused therapy. And a few people who dealt with it who were psychiatrists like me, who felt that in routine day-to-day meeting, we need something different. However, I've heard that before, that reminds other people of coaching. And if you can use it in coaching, I don't mind. I mean, if it was used with me, I wouldn't need medication and the treatment satisfaction questions, but the others might be helpful too. Yes, but it doesn't come from that. It comes from more solution-focused therapy.
There's a question from one of our consultants in learning disabilities. Is there evidence as to how Dialog Plus can be used or adapted for use with adults with learning disabilities, significant cognitive impairment? Yeah,
there are currently studies going on to see how far one can go for that. Of course, there's a limit. There's a limit with all cognitive impairment. There's a limit with dementia patients, and there will also be a limit with learning difficulties. But didn't you know about that? No. So there are. If you write to me, then I can pass you on to people who do research.
Doing some research.
Sorry?
Afia, is she doing some research?
Yeah.
Okay. Last question. Thank you. I have found this very useful for my clinical practice. My main concern is about how to train our NDT colleagues. Like you said, I've seen and heard many people criticizing because not knowing how to make the best use of it.
Yeah, the training is simple, but we still need some training. And as cleverly as we designed the intervention, as poorly we designed the training. We just felt, oh, train people for 90 minutes and then they know what it is, and then the rest, good luck. And that clearly doesn't work. So I think we haven't found the final word on that. The trust hasn't found the final word on that. We struggle with that. But I think the initial training, I'm happy to train. Lara can train, others can train. That is not the problem, but how to maintain then in everyday life that is properly done. You probably need in a team one person who really knows about it and can supervise.
Okay. Yep. Okay. Quickly, yes, please. Which patient groups? That's the question again, but you've mentioned already.
Now it has been used. I mean, the dialogue scale has been used now with all patient groups. Yeah, what I showed you about East London was everyone who's in secondary care. The Dialog Plus intervention now has been used, as I said, with was originally psychotics and mood disorders, anxiety disorders. Now is a large trial on chronic depression. It was used with diabetes patients. So large range.
Okay, thank you, Stefan. So we're going to move on, and the way we organize the program. So we always have an expert talk on these three main themes, and then we really listen to the people actually at the receiving end, really, of what we as health professionals are doing. And we also continue with the theme of face-to-face, but still virtual, because Hajara, unfortunately, had to go home for childcare reasons. So Lara kindly agreed to also present her slides. Just to introduce Lara as well, she's a project lead for Dialog Plus in the Trust, who supports the Improving Quality of Life and Planning Steering Group, co-delivering the training and supporting champion areas on implementing Dialog Plus. And she has worked in peer participation for the last 12 years. Over to Lara.
Thank you, everyone. Good afternoon. As Frank's elusive, Hajara can't be with us, so I will try and do my best to articulate her story. But before I do that, I'm going to just attempt to share a video. Thank you. Or I won't. I'll just delegate that one.
center of my own mental health.
Most of the question is about the service users and what matters to them.
It's become more about what's important to me. It's become more about me. The old care plan had a lot of impersonal questions, and most importantly was filled out by the care coordinator in my absence, and only at the very end, once they'd completed it, they would simply ask me to sign it.
This is live, and it asks the person how they're getting on, what's going on for them, what's their aim, what's their goal, and what they want to do.
So this is different in the sense that I am involved from the very beginning, and the dialogue cannot be completed without me. My hopes, my dreams, what's important to me.
And while doing the training, it makes you wonder, why didn't they bring this up before? Why is it just now? When I used to get my son assessment, I realized what happened last month, it was like a cut and paste for what we had. And I'm thinking, did we do that last month? And I didn't like that.
Service users were brought in from the very, very beginning. We helped to shape the content of the way it was rolled out, the type of questions, the information.
It's not just about, oh, have you taken medication?
It felt very much like, as a service user, I had a big say in what this new approach would look like.
So that helped the person to think more than to just tick in boxes. So having this dialogue is very important. It's a live tool. It's not something that you're just gonna put on a piece of paper, file it away in the cabinet. No, it's something that you look at every time you meet the service user.
It helps boost my confidence, my self-esteem. It's helped me personally to move forward in my journey of recovery.
I like quality of care, and having a dialogue, that's what it brings for carer and also for the person that they care for.
It's helped me to document and see for myself and plot and plan my route, my journey of recovery.
Use it, own it, and make sure the service user voice is heard.
Thank you. And as Sydney was saying, it's about keeping that person at the centre of their care planning. So I'm just going to try and articulate what Hajara will be saying to you if she was here today. So what's in it for her? So Hajara's been only really recognised in the last few years that she's been experiencing, sorry. Oops. Thank you. That she's been using it for the last few years, and she hadn't really recognised what Dialog Plus was before. So I think it's important to remember that for Hajara, it was who is she and her experience and why this is important. So first of all, she's a mum, she's a service user, a worker, a wife, a daughter, sister, and a friend, whilst living alongside a mental illness as well. And it's important that she fulfills all these roles as much as she can whilst taking into account her mental illness. What matters to her is about using her own personal mental health experience to help others, being a mother, being a Muslim, keeping fit, and challenging stigma and what it feels like, what that experience feels like for her. and getting back to work. And one of her goals is to write a book about the mind and soul. So we'll look forward to when she kind of achieves that as well. But these are important to her and her aspirations. So she reflected on her care planning approaches and what that experience felt like for her. So for me, she says it was felt having a plan in place is very important. For me, CPA is about going to a meeting and being told what is going to happen. Being told I am well and I need to stay on medication to maintain my mental health and to prevent me from being unwell and hospitalized, where my children would be without me again. And prevention before it becomes too late. So what matters to her and what's happened and what's not wrong with you. So the CPA care plan has been beneficial while she was really unwell. But when it comes to when she's well, it feels like having a one-way conversation, being told how to stay well, less than that support that she needed. And that decisions were being done alone and decision-making was out of her hands, and always being reminded that she is ill and not being seen as a person. So what Dialog Plus has meant for her, once she recognised this, is being asked how I feel, having a joint conversation, ask what I want, working together to get where I want to be, not always being focused on medication and mental health, building her relationships with professionals, identifying elements of her life that could be improved and supported with, and having that structured conversations. So she's felt that it's overall helped her with her quality of care, her overall mental health, and that she feels part of being a part of her own decision-making within her own life. It has also helped her to set goals, to identify goals and focus on what things she wants to work on, as well as situations where she needs help. And that's why she needs that two-way conversation with the professionals at the same time. Discussing making changes to her treatment, building a picture together, using the scale to see where she is and to help her understand, and that there are no right or wrong answers. The routine meetings are a whole new way to receive support and support. So understanding my own experience. So she would like to see Dialog Plus promoted across all services, not just mental health. So from her learning from that, she is now our esteemed co-chair of the Improving Quality of Life Steering Group. For over a year now, she has also, with myself and Stefan, has delivered training to over 300 members of staff of 28 sessions. It's important we have our steering group as it's service user led. We meet once a month to look at all the work that's going on within ELFT and to see how we can make changes. Within the group, we hear about the barriers and challenges from service users and staff, as well as the opportunities that Dialog Plus presents. And I'm finally going to kind of land on some quotes from some other service users, because it's always good for us to kind of come back to why we're doing this. So this is different. I'm involved from the very beginning, and Dialog cannot be completed without me. Helped me feel valued as I am at the center of my own mental health. Dialog includes my views and preferences instead of care plans previously sent according to what the consultant thought of my current mental state. And I felt part of the shared decision-making. There we are. Thank you.
Different moment, yeah. Let's have a look if you've got any questions in the audience to start with, or comments, any observations. How does that resonate? Okay, let's have a look if we've got anything in here. I think this still goes back to the earlier presentation. Okay, so yes, please.
Thank you very much for the presentation. I suppose it kind of links to the first one as well. Thank you. Yeah, so thank you very much for that. My impression is that dialogue helps the patient to be heard, because I have this theme time and time again, is that we get into a system and it really feels like a system and it's very dehumanizing. So when a patient says, you know, I feel like I'm being heard, it gives me a sense that there's a relationship that is being built here. And I suppose to help us in terms of the practical side of things, there was mention of training for dialogue. Does this mean that in order to build these connections, these relationships, and to really be heard, is it necessary to have a particularly trained person to have that focus, or should it be across the team? I know that on a practical level, I know that it's our nurses who are usually the ones who kind of squeeze the dialogue in the day somehow. And I just have a little bit of unclarity or a little bit of worry that it could be, dialogue could be just kind of thrown in there and maybe lose a little bit of that being heard and that effectivity. So with the actual people who've experienced this, would you know, or could anyone answer, is it that more interpersonal approach through dialogue that is the beneficial aspect to the point where it is having results like CBT, I mean, which is a one-on-one relationship, or is it about being heard as part of the service that they're getting within a team? What would you recommend in terms of who should approach it? Because I often get patients pushing back nurses or pushing back doctors either way, saying, no, I don't want to talk to you, I want to speak to the doctor, or the other way, oh, that doctor's terrible, but I like this nurse. So yeah, I guess I'm thinking about practical deliveries of dialogue and what would be most effective.
So you thought you were going to sit the clock.
I thought I was going to get away with not speaking. I think what we found, it's very much based on sort of individual staff members. I think those who get it, those who feel that it's a good approach, use it well. I think we're starting to see more professions take hold of it now. There's some really good work in Tower Hamlets across their inpatient community from their nurses, where nurses are seeing the value of it, not just in the Dialogue Plus itself, but the potential to reduce duplication around nursing care plans. Peer support workers use it really well, I think, because they've got that experience of coming from a similar background as well. So I think what we're seeing from the very early days, where it was driven often by individuals and leadership at team level, it's started to become a bit more mainstream. And I think the training's helped that. But also I think what this does for me as a non-clinician coming from a lived experience background, it's the opportunity to sort of reinvigorate clinical curiosity by having a really good conversation. And we do understand that can be difficult, but I suppose it's almost giving people permission to do that, which is sort of goes back to Stefan's point about compliance culture. We really want to try and move away from that.
Sorry, I would just like to add, we measured therapeutic relationship in practically all studies. Therapeutic relationships improve, but the end effect is not primarily mediated through the better relationship. So there are other factors in play.
Okay, thank you very much. We're going to move on now to the second part of our afternoon, and the second theme, which is peer support work. And I'm going to introduce our next speaker, which is Steve Gillard, who is a professor of mental health research school at Health Sciences City, University of London. His research also focuses on social and community perspectives on mental health. He has a particular interest in evaluating interventions that are developed, delivered, and led by people who have used mental health services. Over to you, Steve. Oops. Yeah.
Okay, thank you. Just failing to move the slides. Yes, okay. To the best of my knowledge, I don't have a Wikipedia entry. Not that I've checked, of course. I just assume I haven't. So I'm going to kind of give you an overview of peer support, the current state of the evidence for peer support in mental health services. Of course, there's a whole wider world of peer support out there. It's just, what we do when we recognise our shared adverse
adversity and provide each other with emotional and practical support. There's peer support in grassroots organisations, in the voluntary sector, but it's specifically research about peer support in mental health services, and in particular, I guess, about the peer worker in the NHS that I'm going to talk about today. Thank you. No singing. I wouldn't inflict that on you. And alongside looking at the wider literature, I'm going to talk about a couple of studies that have taken place in the Trust in East London too. So I'll begin with looking at some of those, the origins of peer support and the policy context in the NHS. I want to think about what makes peer support distinctive from other forms of mental health care, if you like. It's not just a workforce issue. It's not just an employment opportunity for people on their recovery journey. There's something that the evidence suggests that there's something that's therapeutically very different about peer support. But there are challenges when it comes to implementing that into mental health services. So I'll kind of briefly do that first before looking at the evidence base for peer support, mostly in terms of the outcomes for people who are offered peer support, looking in particular at trials and systematic reviews of the research so far, and then move on to look at the benefits for peer workers themselves, where the literature is less well developed, if you like, and then think, if I have time, a little bit about some of those less tangible benefits of peer support to the multidisciplinary team, if you like, to your practice, and then finish by thinking a little bit about what next, perhaps, for peer support. So, as I said, the origins are out there in the wider world, really. So peer support is just something we do. Organised peer support, I guess, comes from the recent history is varied. So we have in the survivor and patient movement going back to the 70s, things like citizen advocacy and people campaigning for better mental health care. There's a bit of political separatism in there for people who are dissatisfied with care and finding that they can support each other better. There are very well established 12-step programs that have a strong theoretical underpinning that have been with us for decades. And there are things like the self-help and mutual aid movement, things that have sprung up at grassroots level, but the Hearing Voices movement, for example, is a global phenomenon now. So there's lots of peer support out there in the wider world. And of course, peer support's been happening in the NHS too. So we've had things like people coming back and doing ward visits, and in day hospitals and day services, people co-running activity groups and things like that. But I guess more organised peer support in the NHS is more recent, and one of the early strategic initiatives, if you like, was in the Mental Health Trust in Nottingham, where they tried to, with some success, import a model of peer support from Arizona in the US. It's a private initiative, of course, in the US. So these were community mental health teams where the majority of people working on them were peer specialists, as they tend to say in the US, and psychiatry and psychology and so on consulted into the team. So Nottingham has had some success with that, and through an organization called IMROC, which it's a social enterprise now. It was part of NHS Confederation they're one of the leading providers of peer support training nationally, and Julie Repper has led the work there. In terms of policy, the 5-year forward view begins to kind of recommend peer support in mental health services, and there was a mental health workforce plan that followed that. There was a national stocktake of the peer support workforce the end of 2019 that said there were about 860 peer workers in the mental health NHS trust at that point. And the mental health implementation plan calls for up to 5,000 more peer workers in mental health trusts in the years to come. And Health Education England have published a competency framework, a training manual, if you like, for peer support workers, and funding was awarded to organisations to provide that training nationwide. So what's so special about peer support? What makes it distinctive from other forms of mental health care? And people often talk about peer support having a strong values base. So Sherry Mead in the US, who came up with an approach called intentional peer support, talks about the importance of both parties in the peer-to-peer relationship being invited to learn and grow together. So there's reciprocity in the relationship, that it's a two-way process of learning that's arguably very different from the traditional clinician-patient relationship, where one person brings the expertise to someone's mental health. And also that the focus is less on individual change and there's at least as much on relationships. So it's a relational form of support, and that the peer worker somehow embodies that, or the peer-to-peer relationship embodies that change. And Mary O'Hagan in Australia talks about the importance of the equal power relationship, the importance of choice and control over engaging with peer support, the sense of mutual identification, and the last line there, importantly, confirming the validity of experiential knowledge. So the importance and the value in how someone makes sense of their own mental health, the clinical importance of that. And from that, we have understanding, research kind of looks at the mechanisms of peer support, and that there are a number of papers out there looking at this, but this is a project we did a few years ago where we interviewed 90 people in depth who are involved in peer support about how they thought peer support brings about change. And the primary mechanism was that building of a trusting relationship based on shared lived experience. So that connection being made between people, and how that enables talking and listening, enables openness and disclosure. And that leads to role modeling, the idea of embodiment. And we've kind of moved on a little bit, I think, from the individual role modeling recovery to this role modeling of a relationship, a therapeutic relationship. And the other mechanism around bridging and engaging. So that's both the peer worker acting as a bridge to mental health professionals and mental health services, but also engaging with the wider community, connecting to community. But as I said earlier, there are perhaps challenges to implementing this in mental health services. So the question has been asked, can the values that underpin peer support be maintained in a highly regulated environment like an NHS trust, or will the role inevitably become like professionalized through standardized training, risk procedures, note-taking, and so on? And there have been calls for standards and to protect the values of peer support. So support for peer support is very important, and that's something that's been an important focus for the trust here. And research has suggested that unless that appropriate support is in place, the distinctive contribution that peer support might make to mental health care can become diluted. So what's the evidence base for peer support? There's a consistent and growing qualitative evidence base for the experiential benefits of peer support. So people talk about a sense of hope for the future, about feeling empowered and so on. That's a little bit dated, that literature review there. But since then, there have been hundreds of papers published about this. Every other peer support project internationally kind of writes up its research. Early systematic reviews of trials of peer support told us that the peer support was, in terms of outcome, was no better or worse than support provided by other mental health workers. So there wasn't evidence of a significant benefit, but there's a huge variety of peer support out there. People were doing very different things. Peer support looked very different. The modality was very different. So those reviews grouped together group peer support, one-to-one peer support, online peer support. Peer support was happening with different clinical populations, different outcomes were being measured. And also, there was generally, the research wasn't very good at describing the peer support and how it brings about change. And those trials were often of low quality. So randomization and blinding wasn't specified, selective reporting of outcomes, and so on. So there was a lack of clarity in the evidence base. Since then, more focused reviews have emerged. So there's a review of peer support for depression that showed that group peer support is superior to care as usual. There's a medium effect size there in reducing depression, but no difference to group CBT. Mixed results in a review of online peer support for young people with mental health problems, mostly looking at kind of chat room-based interventions. The reviews that started to look at specific outcomes, so a review looking at the effect of peer support on impairment, self-efficacy, and stigma, found that there was a modest effect on empowerment and self-efficacy for group peer support, but not of individual support, and no effect on stigma. The Cochrane review of peer support for schizophrenia that looked at relapses as oh dear, that's the primary outcome. We've been timed out. Can I keep going? Or?
It's during that school.
Yeah.
I don't understand.
We've got to
have to wait for this.
We have to wait for it.
No, we didn't do anything. You have to wait till it. Sorry, it's just loading. I can't do anything until it.
I've done before, Steve.
Yeah.
To be fair, you can carry on.
Can I carry on?
I'll carry on in the meantime.
You can see a small screen.
And online, people can see.
Okay, okay. Apologies online. We lost our screen here. Okay, I'm going to carry on then.
I'm just going to stand here.
Yeah, okay. Yes, so mixed evidence, but reviews emerging that are focused on different clinical populations, different approaches to peer support, but still mixed evidence. And actually all these reviews, I think, combine group and individual peer support. Group and individual peer support are very different things. So we thought we'd conduct our own systematic review. So specifically looking at one-to-one peer support provided in mental health services. So this is a review up to the middle of 2019. So it included 23 papers reporting 19 trials. So one trial greedily chopped their outcomes up into 4 papers. Meta-analysis of pooled data from across trials considered a range of clinical and psychosocial outcomes. Most trials were still of low to moderate quality, but 7 trials were at low risk of bias, more recent trials. So the quality of the evidence base has improved since those early reviews. Most trials compared peer support with usual care or in addition to usual care. Some of them were head-to-head trials of peer workers and clinicians providing similar interventions. So there's a trial of an occupational therapy intervention that compares peer workers with OTs. And still a range of different approaches to peer support. So some of those peer workers were in what might be called paraclinical roles. So they were working in healthcare assistant roles or community support worker roles, that sort of thing. Some of the interventions were structured or behavioral interventions, so things like peer-supported self-management, and others were much more flexible, socially focused, recovery-orientated interventions. What we found was that there was no effect of, when we pulled data across studies, no effect of peer support on symptoms or on hospitalization. Modest positive effects on self-reported recovery and empowerment. You won't be able to see the charts there because they're so small, but standard mean difference for both around 0.2, which equates to a small effect size. But small numbers of studies and only about 300 participants altogether in each group. We also found a significantly greater effect on strength of social network, where peer support was provided in addition to care as usual, versus comparing peer workers with clinicians, but there wasn't a positive effect overall for that. So, I mean, the evidence base is growing up, if you will, but there's still trials are measuring lots of different things in different clinical populations, and we need kind of more research to have a clearer evidence of effect on outcome. With that in mind, we undertook our own trial. When we started this, obviously there was the evidence for peer support was still very equivocal. The quality of trials wasn't very good, but peer support was rapidly being introduced into mental health services. So we thought a good quality UK trial would be timely, because most of those trials are from overseas. So this is a 5-year program of research funded by the National Institute for Health Research. Stefan was an important member of the team. Paul helped develop the peer support. Daniela helped deliver the peer support. So this was a trial of peer support for discharge from inpatient to community mental health care, partnership between a number of universities and mental health trusts. The hypothesis we tested being that peer support for discharge will reduce readmissions in the year post-discharge compared to care as usual. So those are our 7 study sites, a cluster in and around London, and then Birmingham in the Midlands and Bradford in the north. The population were adult psychiatric inpatients with at least 1 previous admission in the preceding 2 years. So a previous admission is the biggest general predictor of readmission, so a population at risk of readmission. The intervention, it was a manualized intervention, so it comprised 8 whole-day training sessions. The supervision and support for peer workers was specified in the manual. Peer workers provided one-to-one peer support, so they were allocated someone to work with. They met them at least once before discharge, and then weekly for the first 10 weeks post-discharge, and then 3 fortnightly meetings, so there was a step down at the end. And the peer support took a flexible approach, so there wasn't a kind of checklist of things that people did, but the peer support training provided peer workers with a range of skills and tools that were focused on individual strengths building and on connecting to community. And the control was care as usual, so follow up by the community mental health team post-discharge. So our primary outcome was readmission within 12 months of discharge. We had a number of secondary outcomes, so time to readmission, number of admissions, days in hospital and contacts with crisis and home treatment teams and liaison psychiatry in the ED. And then we had a number of other secondary outcomes, so quality of life, hope for the future, symptom severity, social contacts, and social inclusion. Before we come to the results, a little bit about the approach. So Frank mentioned the theme of co-production. So if peer support is about people using their experiential knowledge in mental health care, we thought it was important that experiential knowledge was kind of integrated into the way we did the research. So peer workers, people involved in leading peer support services and service user researchers were members of the research team, and the peer support intervention was co-produced with local and national lived experience advisory panels that included peer workers and people using mental health services. Some of that was very effective, some of it was more challenging. So we've written up that work. So we successfully recruited 590 people to the study. That makes it the largest trial of one-to-one peer support internationally to date. And over a quarter of those people were recruited here in East London. More or less half women to men, 60% of the participants were white, 16% black, about 12% Asian, mean age of just under 40. The largest diagnostic group were people with psychosis, about 20% with a diagnosis of personality disorder, and just over a third with other non-psychotic disorders, major depression and so on. So in terms of our results, there was no champagne moment. So we found that peer support was not superior to care as usual in terms of readmission at 12 months. There's the adjusted risk ratio of 0.97 and odds ratio of 0.93. And in terms of secondary outcomes, there was no significant effect on symptoms or any service use or any of our psychosocial outcomes. We conducted some other analyses. So we conducted a complier average causal effect analysis. It's a bit like a per protocol analysis, but a bit more sophisticated and robust. What that does is it looks at a kind of a minimum amount of the intervention that someone would receive where they might expect to experience a difference. And with our lived experience panel, we set that at 2 or more peer support contacts, at least one of which would be in the community, because of the importance of choice in peer support. People are choosing to stay in touch with a peer worker after they've been discharged. And 62% of people in the intervention group receive that minimum amount of peer support. And when outcomes for those people were compared to people in the control arm who our model suggested might have taken up the peer support if they'd been offered it, there was a significant effect in terms of that analysis. And then in our subgroup analysis, we found that participants of any Black ethnicity were less likely to be omitted compared to control than participants of any other ethnicity. So what are the implications of all that? Well, first of all, our primary analysis was very clear. So peer support, as we trialed it here, shouldn't be introduced to reduce readmission post-discharge. And when we combine that with the effects of our systematic review, there is no evidence currently that one-to-one peer support reduces hospitalization. But we might suggest that further trials might usefully explore the effects of peer support on other outcomes, such as empowerment and recovery, as we found in our systematic review. We didn't have that data available when we designed our trial, so we didn't actually test those outcomes in our trial. We also note that we were working with a patient group here that would have presented challenges for peer workers. So these were people at risk of readmission, and actually over 50% of people recruited to the trial were admitted under section at the time, and we wondered whether our intervention was tailored for this particular group. So as I said, we took that very flexible approach to peer support, and perhaps something more structured would have been helpful. Our trial suggests that outcome is related to engagement, and we've done a little bit of work looking at the data. So we asked peer workers to complete a log after each contact, and we found that length of the very first peer support contact while people are on the ward and the amount of relationship building activity that took place in that first contact predicted ongoing engagement, which is interesting. So that kind of reflects the importance of the relationship and peer support. Lots of people ask this, but we found that matching between the peer worker and the person that they were working with didn't predict engagement. And by matching, I mean matching in terms of gender or ethnicity or age or diagnostic group. So that wasn't predictive of ongoing engagement, which is interesting. And then finally, we know that there are inequalities in experience, access, outcomes, the acute care pathway for Black people using mental health services. We have that subgroup analysis, but actually we didn't collect the data in the trial that really allows us to interpret that. So more work needs to be done to better understand issues around ethnicity, culture, and peer support. I didn't start my clock. How are we doing for time? Okay. So just moving on to the evidence for the impact of peer support on the peer worker. So once again, there's quite a lot of qualitative research around people's experience of working as a peer worker in mental health services, that people find it can increase confidence, self-esteem, social contacts, and so on, but can also be a source of stress. And as with peer support more generally, those benefits are undermined where the peer worker doesn't feel that they're properly supported in the role. More recently, there's a growing body of survey research around the impact for the peer worker. Peer workers have reported poor remuneration and job opportunities. This first survey is from Peer Support and Veterans Services in the US, and high rates of stress and relapse, but have also reported increased self-efficacy, self-esteem, and recovery. There are satisfaction studies that have shown that satisfaction can be quite high, so people that can be quite satisfied in the role, and that feeling respected, being given responsibility and good training predict satisfaction. And there have been a number of burnout studies, so using the Maslach burnout inventory that's used in quite a lot of research with healthcare professionals, indicating that rates of burnout are similar to other mental health workers. All of those studies are in the US, so there's clearly a need for something looking at peer workers in the NHS. That benchmarking study in 2019 suggested that rates of absence and turnover in peer workers in the NHS was substantially higher than the rest of the mental health workforce. So absence from work was at 22% compared to about 7% in the rest of the workforce. So there's need for a study that's UK-based, mixed method and longitudinal. So all those other studies were cross-sectional. So we took advantage of the Enrich study that we were working with a group of peer workers for an extended period of time. 32 peer workers were involved in delivering the peer support, and we asked them to complete measures of well-being, job satisfaction, burnout, and interdisciplinary working. We also asked them to undertake in-depth qualitative interviews about their experiences of peer support at the end of training and also after 4 and 12 months in the work. So not a large sample, but actually a lot of data altogether. Looking at the quantitative findings, we compared those outcomes to norm populations, so mostly mental health nurses, and we found that well-being, satisfaction, and so on are very comparable to norm populations and remain so for the duration of the study. Burnout was actually lower than our comparison populations. We did find reductions in well-being and some of the satisfaction subscales and an increase in burnout at 4 months, but this wasn't maintained at 1 year. We can come back to that. Satisfaction with training and career prospects was lower at 1 year. And there was some evidence of decrease in the score for interdisciplinary communication. We found our absence rates in Enrich were about 7%, so equivalent to other mental health workers and lower than the 22% in the HEE reports. And maybe there was something there about support for peer workers. In terms of our qualitative finding, peer workers said they felt valued, so they found meaning value in using their experiences to help others. They felt proper pay was symbolic of recognition and of being valued. So all the peer workers in Enrich were on proper NHS pay scales. They weren't doing bank work or casual work. They started off very optimistic about the future. By the end, they were hopeful that there were future work opportunities. They felt empowered, so being a peer worker had a transformative impact to personal growth and so on, but could be emotionally and practically demanding. People said they needed time to adjust. So there was that kind of reflected the survey findings that said things were tough in the first few months of the job, but with proper supervision, people felt supported. And feeling connected was very important. So the importance of supervision and connection with the peer worker team, people spoke about that leading to a better sense of connection to the self. People felt they learned through interaction, through the work, but there were demands around connecting or over-connecting in the job, and supervision was very important there. And again, reflecting the quantitative findings, there was a lack of connection sometimes with the clinical teams. Am I okay, or do I need to? A couple of minutes. Okay. Let's skip that. So very briefly, what are those wider kind of clinical benefits, if you like, to the multidisciplinary team of working alongside peer workers? Well, there is research that suggests that peer workers can act as a bridge between the service user and the clinical team. Alan Simpson did a study in East London that spoke about the kind of liminal nature of the peer worker role, sort of being in both camps, speaking both languages, if you like, so being that point of connection. And also, as we noted earlier, that relationship based on trust enables disclosure. So we interviewed peer workers who said that they felt they could talk about stuff, service users who said they felt they could talk about stuff to their peer worker that they couldn't talk about to the rest of the team, even though they knew that would go back to a team meeting. But that was okay because of that trust. Peer workers bring different insights to the clinical team and expertise based on experiential knowledge rather than a kind of professional based knowledge. So, I mean, the whole point of the MDT is that people bring a different framework, a different way of understanding and making sense of mental health to someone's clinical care. And if you like, this is another knowledge base. It's another approach. And that peer workers could act as cultural change agents within teams. So yes, challenging casual use of stigmatizing language, but also challenging assumptions about, how someone is, what's going on because of the way that they present that might close down how we think about people's mental health. So finally, what next for peer support in mental health care? So there's a need for more focused peer support that's targeted at particular clinical population and where the function is specific. I think the history of peer support in the NHS was perhaps that people would do a basic training and then they'd just be allocated to an inpatient or a community mental health team and left to get on with it. And I think things are moving on with that. And the trust here is developing much more specific roles. A couple of research initiatives in the trust. So the RAPID trial will be starting in July. It's a trial led from Manchester of remote interventions for people referred to home treatment teams for suicidal thoughts. It's a multi-arm trial, but one of the arms is a remote peer support intervention. And we have some follow-on funding from the NIHR from the previous study to look at trauma-informed peer support for people using complex emotional needs services. Enhancing skills among peer workers is clearly very important, and ELFT has developed a training that's accredited by the RCP, and also issues around progression and peer leadership. What next after the first year in the job are important. And there are lots of opportunities around peer support and community. So we do have persistent problems with inequality in mental health care. And there are solutions that there in communities, there's expertise within communities that the Trust Community Transformation Programme is addressing. So we completed a study recently, a collaboration with community researchers at the Bromley by Bow Centre that we're writing up around peer support for women from South Asian communities. And again, our follow-on funding from the NIHR will be addressing those issues around culture, ethnicity, and peer support. Thank you.
Thank you very much, Steve. Given the technical challenges, we are going to take a couple of questions and then we will have the break first, and then we can fix really our screen here. Maybe I start. I think it's a nice example to demonstrate the richness of research, because you mentioned challenging assumptions. Really, it challenges also assumptions along the lines of really a common sense kind of agenda. I mean, peer support really helps on all kinds of accounts, which is obviously not the case. But I suppose the other kind of sort of message that you delivered was the therapeutic relationship again, and that kind of reminds me of the research in all kinds of sort of psychotherapy modalities across the board. The generic factors seem to be much more relevant than the specific techniques. Do you see like some comparison there to the psychotherapy research in that sense?
Yes and no. I'm sure there are general factors. So when people talk about what they value about peer support, there are things like good listening, respectful listening, and so on. But I think there's another dimension to it, which is around the reciprocal nature of the relationship. So there isn't one person who's there as expert, and the other person is there who's someone to receive help. So it's a different type of relationship that offers something different in the context of mental health care.
So maybe that's then the other way around, the take-home message for psychotherapy, really, that psychotherapy has to be sort of engaging and not really the kind of sort of I do something for or to you type approach.
I don't know. I mean, as I said, you know, people from different professions bring a different approach. They bring a different framework, a different understanding of mental health, and that has value. Peer support doesn't kind of negate that value. It's offering something that's different.
Question in the chat: has there been any studies in the effect of the coronavirus pandemic on peer support?
Not to my knowledge.
Okay, clear answer. Stefan?
I have a question. So it is clear that overall there's no effect on rehospitalization. So what's your impression? Is that because rehospitalization simply can't be influenced by peer support like the weather, whatever peers do, no effect? Or that positive effects like support and good relationships are outweighed by detrimental effects like being burdened more, being more reminded, being close to services? So do you think there are detrimental and positive effects, or simply nothing?
I think it's the former. So there are detrimental and positive effects, and I think there are so many other things that impact hospitalization that maybe have a larger effect than peer support.
Any other questions in the audience?
So it's unfortunate that we didn't measure other things in the trial.
Thank you for that. I was just wondering, you mentioned about how peer support is not necessarily like the other professions in terms of very professional approach, the way things are done. It's more flexible, it's more individualized, experiential. Has that affected the ability to research this in our traditional methods? Is that why a lot of the studies were not necessarily very large effect? Because you really can't really tap onto those specific outcomes.
Yeah. We had discussions about that in the study, and I guess there are some tensions between peer support and, let's say, the randomized clinical trial, because what in effect we're doing is we're randomizing someone to build a relationship or not, and we're allocating someone to a new relationship, and that's kind of counterintuitive. That's not to say that the peer support can't be effective in that way, and people did build strong relationships. There's lots of positive quality data about that, but there is a tension there between research and peer support.
Okay, thank you very much again, Steve. We're gonna have a break now, and there is tea and coffee, I think, out there, and we're gonna start again at 4, please. 4. Okay, so good to see that you're still here after the break. And it was actually, I have to say, despite the fact that we are a small group, it was wonderful to have a coffee and tea break together and just to have a chat about what we just heard. I mean, it feels like we are moving back into real life with real people. So I would like to introduce our next 2 speakers. We're going to talk about peer support from a sharing experience perspective. Daniela Hartnett is the professional lead for peer support for ELFT, working in peer support since 2017. And clearly somebody who is very driven really to bring this into play for service users. And then there's my colleague, Dave Bailey, who is a consultant psychiatrist in East London. He actually works for the East London Rough Sleepers homeless team and also works in the community in Newham. He trained in East London, has been part of the Buta Bika East London project, a health partnership with mental health services in Uganda, since its start in 2004. It's already that long, we didn't know, yeah. He's been involved in developing peer support services over the past 12 years, collaborating with colleagues and service users to develop and deliver peer support in both Newham and in Uganda. And he's the consultant lead for peer support in Newham. And I'm not too sure who's going to start. Okay, thank you.
Cool, thank you for that. Frank? I'm scared of pressing the wrong button. Cool. Okay, brilliant. So I'm going to talk a little bit about the evolution of peer support work over the past 15, 20 years here in East London, talk about how some of my own understanding has been influenced from learning of the collaboration in Uganda, talk a bit about the training, and then Daniela is going to talk about where we are now in terms of peer support work and what our plans are over the next few years. So peer support work in East London started back in 2005, developed into a research project led by Alan Simpson and others, where service users were recruited and trained in peer support work and supported people at the point of discharge. The primary outcomes at that time were loneliness and quality of life, which it did not make an impact on, but it did show a difference on the secondary outcome of hope for service users who were supported by peer support work. And then over the next few years, this kind of embryonic peer support work slowly developed, but often in quite isolated pockets, led by people with some local enthusiasm. There was general senior goodwill to the movement, but the numbers of peer support workers in any service was very small. They were quite isolated. There was a lack of funding, which meant that people didn't have kind of job security, and there were lack of systemic structures that could really support them to do the work going forward. And there were all the challenges of developing a new professional group within a trust. So alongside this was the work that we did in Uganda. We got some funding in 2011 to develop community mental health services that were very limited. We trained up 30 peer support workers who were able to support people at the point of discharge from hospital. In our second Brain Game project, we were able to get funding to develop a recovery college at Buta Bika and bring peer support work onto the wards and into 7 of the 13 regions around the country. In 2018, we spent some time developing communities of practice, thinking about codes of conduct and protocols to allow the peer support work really to be embedded into services, and got the Ministry of Health involved to look at ratifying the training and the approach really that would allow us to use it in other services around the country. And over the past 9 months, we've been involved in bringing peer support work into refugee resettlement areas in the northwest and the west of the country as a way really of bringing some mental health expertise into those regions. And so some of the learning that we took from that, you've heard that Stephen talk about the evidence base about the impact on clinical outcomes for peers who receive peer support work. But the real impact that we saw was very much on the quality of experience that service users were getting from services. There are also benefits for the teams and for the system, the benefits of co-production, working alongside service users, changing the relationship that we have with service users. And this is quite transformative, people having higher expectations of what they would expect and also being more willing to take positive risk. But maybe the most important people to benefit from this approach is the peer support workers themselves. And I don't think we have to be apologetic about that. I think we should be quite explicit and harness this. And so see peer support work potentially as part of a recovery care pathway, an aim for most people within services to benefit from this, either to receive peer support work or to benefit from the training, which can have a real positive impact on people and working as well. Our feeling is that peer support work training should be inclusive. The main inclusion criteria should be that people want to get involved, that they should be passionate and they should believe in the model. And a couple of other things to note is really one is around the power imbalance that we've heard a little bit about earlier, just to be aware and to acknowledge that and try and take deliberate steps to try and counteract that. And that can be done by having large numbers of peer support workers within teams, making sure they're not isolated, that they're central to the team, that they're a part of it and they're embedded within teams. And the final point to make really is this issue around recovery not being an individual thing, but being a social and political issue. And there is something about measuring individual recovery, but recovery is more powerful when people use their wisdom, their knowledge that they've got through their recovery journey to be able to advocate for others and then to use that experience to support others. And so bringing some of those ideas back to Newham, we got some funding in 2015 to get a number of peer support workers come into our community recovery team in the Northwest. They worked on a model of having a caseload of up to 5 service users who they would support for 12 sessions and focus on helping them to achieve specific goals they collaborated on. Of those initial peer support workers who worked with us, several of them have gone on to full-time work. And also importantly, several of the service users who were supported then have come in to do the peer support work training themselves and be part of the approach. Stephen alluded to some of the issues around bank work, and that was a real issue early on, and it felt quite ethically dubious to be involved in having colleagues who are on 0 hours working with all the kind of instability that had to them individually, to their mental health, but also to the system. And crucially, we lost a lot of good peer support workers to other trusts that were offering better opportunities at that time. So we're really pleased in 2018 when we were able to get permanent contracts for our peer support workers and starting to have some career progression for people, for peer support workers through the system as well. And then in 2020, there's the funding that's come through from Transformation, and that has given us another opportunity to really expand peer support work. So I'll talk briefly about the training, and there are 3 levels of training to think about. The first one is for the peer support workers themselves, so for the training that allows them to be workers, peer support workers, but then also the training for the supervisors and also the training for the teams that are going to take on peer support work. And really this is thinking about a systemic readiness to make the change and to be able to welcome and support peer support workers coming into the teams. So the first one on the training itself, the peer support worker training, we aiming to offer that up to 4 times a year. That has been local and is now mainly trust-wide. Appropriate people who are interested can apply, and they will be selected so that 15 trainees can take part in each training, which is 1 day a week for 8 weeks. The training is led by accredited peer support work trainers with some input from non-peer support work colleagues, and the training itself has been accredited by the Royal College of Psychiatrists. And at the moment, the expectation is that most peer support workers recruited will have completed the accredited East London peer support work training. The training, there are 8 modules, and these are based on the various competencies, which is around understanding peer support work, thinking about sharing stories safely, thinking about recovery, communication skills, thinking about challenging stigma and discrimination, paying attention to the potential difficulties around relationships and thinking about boundaries and safety of peer workers, a focus on keeping well at work, making sure that people think about how they would look after themselves and how they would communicate issues around their wellness at work, and issues around cultural competence and diversity as well. So we had one training in 2020 that we had recruited 15 trainees for the course that was due to start in April 2020 when we went into COVID lockdown in March of 2020. And so we very quickly adapted the training so that we could continue with that, and we did that online. 14 of the 15 completed the course and had good outcomes in terms of their confidence and feeling ready to work. And 11 of those were then recruited into transformation posts in primary care. So it was quite an interesting scenario where people had done the training, been recruited, and then actually started working as peer support workers all online, which in some ways is a very significant achievement. At the same time, there have been problems around developing a kind of group cohesion and identity that has had an impact there as well. So then training for peer support work supervisors, when there were small numbers of peer support workers, a lot of the supervision was done by OTs who were quite experienced in supervision, but as the numbers have expanded, more people who have less experience in supervision have been recruited to take on that role. And so there's identified a real need to have some consistency around that supervision. The training of supervision is also along the same principles of co-production and co-facilitation with people who've worked as peer support worker supervisors and peer support workers who have received supervision, then training others. And again, there's a real focus on well-being and wellness, given that working in mental health is stressful to all people, but particularly people who have a vulnerability to stress, to think about how to support people in their role and how to support them when they are struggling as well. And then finally, a word on training for teams, getting teams ready to have peer support workers work within them. And this has been educating about the role of peer support workers, what they are, what they do not do, an emphasis on the unique therapeutic ingredient of lived and living experience, and trying to elicit out the potential benefits that people will get from having peer support workers in their teams, but also trying to delineate anxieties and concerns and trying to help people problem solve those before peer support workers join. And then once peer support workers join the team, often people have come with difficulties. And I guess our approach has been to try and help people reframe them rather than seeing it a problem with a peer support worker or a problem with a peer support worker approach. Sometimes what it does is highlight problems in the way that we as a system function to support people. So we could actually use that as an opportunity for learning and changing the way that we work as a system. So that's what I've got to say, and I'm going to hand over to Daniela.
Hi, good afternoon. My name's Daniela and I'm a colleague of Dave here. And also thanks so much to Steve Gillard there to talk about peer support and the development there. But what I'd like to focus on at the moment is peer support and the explosion of peer support within different trusts, and how the terminology has been used and then somehow diluted what we as peer support workers do within East London Foundation Trust. So we've got a number of roles that are developing. I think Steve said that the workforce of more than 5,000 are expected from Health Education England. And with that, there have been lots of opportunities for peer support work roles. We've got peer support work roles with care navigation, social prescribing and others. So care navigation will be personalised support, assessment for social care, and also thinking about directing on to other services. But with care navigation, it's still not peer support. So you will not find that there is that mutuality, the autonomy, and also the sharing of experiences there. Care navigator will support somebody to get there, but won't necessarily understand because they wouldn't have had that living experience. And much the same as social prescribing, when we're thinking about activities there, a facilitator or navigator to help bridge between primary care professionals and social opportunities. Very good work, very good thinking about going back into communities, especially where people have been hospitalised or have been using services for such a long time, reducing that isolation, but still there may be the lacking there of understanding and having that experiential knowledge to be able to share together within those peer relationships. So other roles where there are potential for well-being coaches, which are being rolled out, well-being coaches are specifically thinking about peer support within physical abilities, supporting for self-management, for instance, shared decision-making between professionals and the people they support, and personalised care plans. However, there's possibly a lack of, a loss of mutuality within that relationship, as there would appear to be a little bit of an imbalance there. They may not have living experience or understand what it's like to give and receive peer support in that way. Power imbalance, I think we've all heard of peer tutors. We have them in universities, also within our recovery colleges for mental health and physical health. And peer tutoring includes a range of approaches in which learners work together in pairs or in small groups. It's a fixed role. And it's a common characteristic that people take on, especially if they're perhaps in their second year of university, able to support somebody who's coming within their first year. There is a power imbalance. Often a tutor will be seen as somebody who's got experience of that, which we do see within peer support. However, there is a slight hierarchical and imbalance there. So we also have peer mentors, which we do have in East London Foundation Trust. And mentoring has been defined as giving mutual benefits and setting out goals. Very, very useful, and something that we do provide in peer support and thinking about within the dialogue stage there as well. But there's a lot of person-centered care there, identifying those needs that people really need within their lives for better outcomes. And peer mediators, lots of autonomy. We want people to be able to self-advocate, not somebody advocates on their behalf. We want people to be able to live their best life and find the right spaces for themselves and not be told or done to, but alongside, rather than mediation coming in to think about how they might address something for individuals. And lastly, another role that we do have within peer support, especially for younger age groups, is peer champions. But when we think about the word of peer champion, we're thinking about, of course, being responsible for proposing initiatives and responses and identified community needs. Who are we really speaking to? But that's more on the organisational level and not necessarily for the people who are using services and receiving them and giving them as well. That's more on an organisational level. So going back to what peer support within East London Foundation Trust and how we've developed, and the definition that we are currently using at the moment It offers a unique perspective that can be used to improve mental health services, as you've heard, and also for the better outcomes for service users, but also for the peers themselves. So peer workers are individuals who have mental health issues, and if use services, they can best navigate the services that actually need to be attained within the community because they identified and had that experience themselves. On the role, of course, peer workers should be caring, and I think that we're hypersensitive to others' experiences because we've received services ourselves. Good listeners, hopefully, good communicators. I hope that that's going down very well here, and knowledgeable about recovery, committed to person-centered approaches there. So the success of peer workers is based on the ability for them to use a lived experience with their peers, with autonomy, mutuality, social connectedness, hope, and reimagining, and creating new living experiences in teams as peers find their way through a service can be disconcerting for all of us. We are creating new spaces for peers to feel comfortable with diagnosis and accessing care. So I'd like to just go through the current setup of peer support workers within East London Foundation Trust. So as you can see, trust-wide, we've recruited one peer support professional lead. We've now recruited a training lead, as my colleague has stated, we're running training 4 times a year for peer support. And that is also accredited by the Royal College of Psychiatrists. We also have locality of borough leads, where that's been very, very important for support of peer support workers who are coming in, may need advice, may need support around supervision, may need support about understanding and bringing people together and thinking about what the outcomes might be within their respective boroughs. As you can see there, across East London Foundation Trust, we have persons who are inpatient peer support, crisis intervention, and neighbourhoods which have just been developed after enhanced primary care and come from the transformation that started in 2020. And also thinking about that crisis intervention as well. And just to have a little bit, look a little bit further where we are developing into newer roles as well. We have one peer support worker who is actually carer, and that's really, really, I think that's quite a unique role because it offers families and persons who are living with persons who may not understand and listening to somebody else who's been through that, having a peer support worker to show it can be done. You can remodel or you can reimagine and you can work. It can be really hopeful. Perinatal, across the trust, we are broadening with peer support for that. Young adults, we've recently done a set of training for that along with eating disorders because we found commonality for young adults and eating disorders there. Liaison and diversion service, we have one actually in Luton, Bedfordshire. I think somehow it's fallen off the slide. I'm glad that it's not fallen off here. We also have complex needs, community engagement and psychology. We're really, really looking at how that happens within the community and how people access that and having peer support there at the forefront. Community health services, something that we're really, really keen in developing. We have 2 peer support workers working in Tower Hamlets, so very much the vanguard at the moment of peer support within East London Foundation Trust, and also the continent service. As you heard my colleague mention, who works in the Sleepers project, we've just recruited a person, and that's going to be regional, so it's going to be throughout the 3 regions there, the Newham, Tower Hamlets, and City and Hackney. We've just actually successfully recruited for pharmacy, a peer support worker there, and look at the ambiguities of somebody saying, well, I don't really want to take medication, but what's the best case scenario? And thinking about where to go for additional information and having those conversations with medical professionals and thinking about having those conversations where it's a mutual relationship between a clinician and the person who's using services. And as Steve mentioned as well, we've got the rapid trial. We've successfully recruited a peer support worker to work with crisis intervention, and that's going to be led remotely. And hopefully we'll see, we'll hope to see what the results are from there, and that's an 18-month post. So also the other reason why I'm up here and talking about peer support here today is thinking about the training. Unfortunately, my colleague can't be here today. I'm hoping that she's in the virtual audience. The governance of peer support, the supervision, as was mentioned earlier, handbook, and also supervision again. Apologies for the typo.
It's really important.
It's very important. So I just want to show you our charts of peer support training currently within the trust. And as it has been accredited by the Royal College of Psychiatrists, we run it 4 times a year. We have persons who have experienced peer support workers to facilitate with the training. So the process for that, and there are a lot of assessments before the training actually starts, and when we went online, that posed some challenges, but it actually sped up the process of us being able to identify, and for peers to be able to identify whether this is the right route for them. So we have a number of assessments that take place throughout the training. So we have an expression of interest, learner agreements. The training is self-directed with learning objectives and competencies there. There's also a midpoint tutorial, which is really important for that. Submission of completed handbook, which is then assessed, and a 500-word assignment. So as you can see there, there's lots of processes that take place, but also within those specialities, we do have bolt-ons where we may have additional extra days of training. So it may be from 8 weeks to 10 weeks training. Thank you. So this is nearly figurative, as it just displays the recent training that we've done and the modules there, and also the competencies which are due to be met. And I'm going to probably try to speed up a little bit. We have peer support governance, and these are some of the areas. So as my colleague mentioned, supervision is very important. Support for peer support workers, steering group, which we bring together additional areas which may be challenging, but where policy is developing, and also for that co-production, which is super important in peer support. Where are peer support workers? As you've seen, they're everywhere, but here is one of our extremely talented peer support workers with QI, who used QI to think about her own recovery focus and also within peer support. And now she's got a full-time paid job. There are a number of slides here that actually I haven't done justice to be able to go through all.
Can send the slides out. Yeah.
Okay. All right. So thank you so much for listening. We'll send the slides out, and thank you for listening.
Thank you very much. I think in the conscious of time, just one brief question. Peer support worker are people who've got lived experience and mental health issues, you said. To what extent is that a career pathway for people who come from a professional background in mental health care who might want to choose to go through peer support back into work?
Yeah.
So if I can just say, first of all, for people who do want that pathway, I think Dave discussed that it's a pathway that needs to be interesting, that somebody actually has living experience of. So you might have all of the degrees in the world, really understand healthcare, but understanding from a living perspective to be able to make those connections. Somebody who is who's used mental health services, understanding the power imbalance, the self-stigma and the stigma around them as well.
You want to add something to that? Okay, fine, good. We're moving on to the third topic of the day, befriending, and Stefan Krieber has kindly agreed to also cover the evidence base and some controversial learning lessons from that specific topic. Thank you, Stefan.
Yeah, thank you very much. Again, now we're coming to something completely different, as Monty Python might say. Befriending, idea, practice, and the evidence. So what is the idea? The Oxford definition is to act as or become a friend. So it's not befriending, is not be a friend, a bit more. Someone with someone, especially when they're in need of help or support. In healthcare, there are a range of models. The term doesn't have a copyright. So for instance, there's a famous trial on CBT where the therapists then in their control group were just nice and talked about the world with the patients. And they call that befriending. Not surprisingly, at the end of treatment, patient with befriending has improved as much or as little as those with CBT. But that was then done by professionals. However, generally, it is a relationship of a patient and a volunteer, somewhat arranged and organized. And there's an inevitable tension between the two extremes. So is it a real friendship, in which case the organization would be more like a dating agency, just bringing people together that then can do what they like? Or is it very regulated, in which case are volunteers then unpaid professionals and they should be properly paid? One question that makes that possibly clear is, can a volunteer, a befriender and a patient, can they have sex with each other? Now, if you're in a professional relationship with, oh God, no, not only no sex, please, we are British. No, it is, of course, how can you, a vulnerable person and someone else not employed, but in a formal role, of course it is unacceptable. If you go to the friendship side, you would say, no, of course, I mean, who is so arrogant and paternalistic that they interfere with two adults wanting to have consensual sex? So this tension cannot go away. Who would disagree with this? Friends much cheaper than a psychiatrist. All of us would prefer that, I guess. There are potential benefits. There are potential benefits for the patients: increased confidence, better mood, increased social activities. There's some evidence for that. There's benefits for the volunteers, rich new experience, understanding of mental illness, but there's also potential benefits for the community. It reduces social distance. We arguably end up with a more cohesive community. And I find it interesting how much research focuses on stigma, on blaming the public, how badly they behave towards mental illness. But there are thousands and thousands out there who spend their free time unpaid, something that we would not do because we get paid, to help people with mental illness. And there's very little about that. So the research, there's a great variation of programs. So it's very different whether it's run by a church in Southampton or community organization in the Austrian Alps or by a sports club in Italy. Always completely different programs. So there's a wide range of patients with very different characteristics, also very different wishes and very different preferences. And we talked before about peer support, and we always offer that as one more or less defined thing like a treatment. But people's wishes vary. There's very little systematic research. It's even worse. We've done a large research program funded by the NHR by $1.5 million. So we applied for that. Applicants were 15 very, very clever academics. Then it was reviewed by 12 very, very clever reviewers, looked at by a panel, 20 people, also very clever. And we suggested things like, now first we randomly select 12 schemes from the NHS in London, and then 12 schemes. Nobody of these experts had any idea that is total rubbish, because those systems, those schemes don't exist. And it took us a while first, several months of depression, when we went through not finding any befriending schemes. And then we realized that there was something here, but often run by 2 old people and a dog, with an office opened every other Tuesday from 3 to 5. And then their website, go to websites, volunteering websites on mental health. I mean, it's an interesting experience. 90% of what you click on is outdated. And that was before COVID. So nobody in this country has any idea right now how many befriending schemes there are, how many people benefit from that or not. The evidence shows there's, even outside mental health, by the way, there is probably, possibly a tendency for better patient-rated outcomes, in particular depression. So if you get a befriender, depression tends to increase. Now the volunteers, very limited research in the whole world. We found data of 577 volunteers, and more than 300 of them were from ourselves. So nobody knows who they are. However, what we do know is there's no typical befriender. Most are female, mostly older. So one cluster are elderly women where the children have left home, who are not professional and look after a younger patient. So that's very often the case. I talked about stigma. Again, not surprisingly, befrienders have a lower desire for social distance than the general population, and also lower desire for social distance than psychiatrists. Yeah, just to emphasize that. The motivations are usually split. All want to give, not all, but usually they want to give something. There's this altruistic thing, give something to society, but there's also the getting, experience, different impression, something new. The experiences in qualitative research are largely positive, but I mean, those volunteers who use the schemes, they are rarely interviewed. So that is pretty easy to achieve. And befriending in mental health care, the effects on the community, there's no research at all where that makes any difference. So in East London, we did a randomized controlled trial. Patients with schizophrenia in the trust and secondary services who reported some social isolation, either should have one-to-one befriending, meeting once a week for 1 year, or treatment as usual plus an activity booklet. Sounded very well, and people felt, yes, that should be funded. The volunteers, and I just said earlier, most volunteers in the world, I mean, based on 600, are elderly with spare time, usually engaged in charities. Here they were mostly female again, but the average age was 28. The mode age, the most frequent age, was 21. So we had young female students from Queen Mary, who were most of the people, and they aspire to working in mental health. Nothing wrong with that, but it's of course something completely different in terms of relationship, and 70% with previous experience of volunteering. The patients, average age 42, most male, long length of illness, and 90% unemployed. So again, instead of the elderly, nice ex-mothers who look after a younger patient, we had younger female students looking after a middle-aged man or woman. I mean, that comes with its own challenges and aspects for relationships. Only this, we allocated to intervention 63. So 14 never met. Only 44 made it to a third meeting. Only 31 had more than 12 meetings, and we wanted them to meet once a week. And the super compliers were only 9, and that's only 50% of what we wanted. But then these are volunteers. You can't just tell them what to do. You need to ask them. The results. Primary outcome was time spent on social activities, self-esteem, observer-rated symptoms, self-rated depression, subjective quality of life, nothing. However, people in the intervention group had more contacts with different people after 12 months, and with very sophisticated methods, we took the contact with a volunteer out of that. So the volunteer was told not to meet in the week when we assessed and all that. The difference was upheld 6 months later, so fair enough. Whether that is good enough, but at least a little bit. And further trials in Bosnia and Herzegovina and Colombia and Uganda had all positive findings, which we may present in September, much more positive than we had. Patient experience. I feel more confident about myself. I feel like people understand me more, that there's somebody that can be there. And she always talks to me about my feelings, makes me feel better. She made me feel like I could do stuff. Or I really value the friendships that me and her have made now. Do see us being friends for a long time. Or that's what was helpful, being treated like I was, normal and worthy of respect by a normal, respectable member of society. In that respect, it makes you feel you fit in, you know. Or I feel more confident about myself. I feel like people understand me more, that there's somebody that can be there. Or she, and that is a volunteer, came back and said, I've graduated. I've got a first-class degree. On that day, I felt ecstatic. What do we need a randomized controlled trials for? If a person feels ecstatic about what someone has achieved who they like, I mean, what is life about if not about that? However, there were also dropouts. For me, it felt like she didn't want to be here, like she was being forced to come and meet with me. So that gave me a bad impression of her and the whole scheme. Or if she was too busy, maybe she should have told you guys, and I got matched with someone else or something instead of just waiting on her and not showing up and not calling me. And of course, for the volunteers, it wasn't that easy either. At some weekends, I was thinking, I'd love to spend it with my boyfriend. I've loved to go away with my friends, but I haven't seen the Befriending for a week, and I need to see her. Or throughout the scheme, I had the feeling that she felt like I was either her counselor or her support, that I was part of some services. That leads to some questions, and the answer to all of those questions is no. And I won't go very much into that, but it challenges this type of research. So can befriending be standardized and manualized to be evaluated in a trial? I'm very much in favor of more research, but I wouldn't do another trial. I think it is simply not like a drug. Can befriending be targeted on consistent outcomes across different people? I mean, is it the same that Joe Blocks wants to do and Sue Miller? I would again say no. And most important, are changes over time relevant for evaluating befriending? Just imagine after this year, now we all go out and you find someone very nice over a beer and you say, oh, could be a friend. You don't go say, oh, let's decide what we want to achieve over a year. And probably after you wouldn't say that afterwards. So what have I really achieved with that friend? Friends are there that we have got good times, that we enjoy companionships, that we are happy and angry with them, and then friendships last as long as they last. So I think the whole model, which the NHS, of course, needs to fund this, because they want to pay for that and want outcomes and all that, I think it doesn't apply. The recommendations, finally. So first, it is not cheap. It's cheaper than a psychiatrist, that's true. It's not cheap. If it is run in the NHS or elsewhere, it requires costs and sustained costs and organization. There's no one size fits all. We'll probably need different programs for different people. Possibly, I'm not sure that the NHS is the right organization for that. Maybe within and outside of the NHS. We need to set and manage expectations. However, if we manage them too well, then maybe nobody wants to do that. We need programs that are flexible and accommodate and adjust to preference of patients and volunteers. Something I learned in the meantime that we didn't do here, I hope that will be done in ELFT in the future. What has been done very beneficial in other organizations is for the volunteers to have their own network. So not with the patients, just their own network, that they felt part of a team. And you would always say that in the NHS, as little bureaucracy as possible, and it always goes in the other direction. And with that, I thank all the ones that have befriended me and let me befriend them. Thank you.
I suggest we go directly to hear from our local scheme before we then have a few minutes to talk about the ethical and other dilemmas that comes from that particular scheme. So to introduce Matt Preston, who is our befriending service lead, and he's supported by Paul Winfield, who you saw earlier, who I would also like to introduce because he's the director of people participation. has worked to advance the voice of services, patients and carers in mental health for over 13 years. Paul works internationally with healthcare services regarding co-production, value and quality improvement. And he's of course passionate about social justice. So over to you, even though it's a double act.
Thank you. I brought my notes on paper in case they try to pull the plug again. So should stand me in good stead. So hello to everyone. My name's Matt. I'm a service user from East London, and I'm also the lead for the Befriending service. I've worked with PP and ELFT for a number of years now. We've worked on several different projects together. And my sort of personal focus is improving well-being and reducing stigma for people experiencing mental health difficulties. So yeah, however, a lot of our projects were disrupted by something you may or may not have seen in the news, which was a thing called COVID. I say disrupted because ELF really didn't sort of miss a beat when it came to moving our services and projects online so that they can continue on and we can carry on sort of doing the work we're trying to do. But what about the service users who didn't have access to online services, video calls, things like that? So we set up the telephone befriending service as a response to COVID, lockdown, and the isolation that a lot of our service users were facing. We provided phone calls outside of a clinical setting. We service users to talk about what they saw on TV last night, weather, what their football team's doing, you know, things like that. And that was sort of part of the day-to-day conversations that were sort of missing in a lot of people's life. So to give that back felt like a very, very rewarding thing to do. After lockdown eased, the service was expanded to all secondary care teams, and we continue to deliver our calls to service users as loneliness is not really something that's limited to a pandemic. Sadly, I think that people are always going to be sort of isolated and lonely due to a number of different social factors. And the service has been running now since March 2020. We operate with around 30 to 35 befrienders. We get around 5 to 10 referrals a week, and we've got over 100 service users which receive their weekly calls currently. So there are two key factors we can attribute the success of the service to. Firstly, as I've touched on, we're not a clinical counselling or crisis service. We feel that social need to talk about the everyday away from the doctors, the clinics and the medication. Secondly, and perhaps more importantly, all of our befrienders are ELF service users. So they've sat on those wards feeling hopeless. They've had that side effects from the medication. They've faced that stigma when they're trying to rebuild their lives. So they're experts by experience. And the way we're uniquely staffed and managed by service users gives us the edge. Not to try and put ourselves in the shoes of the befriendees, because we already walk in them. ELFT has always sort of had service users at the core of what it does, but to have a service that's completely managed and staffed by service users from start to finish gives us a huge impact on how we operate and how the care is received by our service users. One sort of unexpected but useful side effect to this is we've managed to highlight a number of safeguarding issues where service users have felt comfortable to tell us something that they didn't really want to share with their clinicians. I think this is largely because there's still a bit of a fear around being sectioned if they say the wrong thing, or if they feel they say something that's quite extreme, suddenly they're going to get taken away and locked up, which is, we know isn't the case for a lot of cases. But we've been able to feed back these safeguarding issues to responsible clinicians, which would have led to sort of serious harm or for our service users if left kind of unchecked. We've been able to get some earlier intervention care and avoid sort of a much more dire situation for the service user, avoid lengthy hospital stays, etc., etc. And during the time they're with us, we contact our service users at regular intervals throughout their time. We operate a set of set questions designed to measure their engagement and benefit from the service. This information is stored and periodically reviewed. We keep a record of our service users, which we use both sources of data to evaluate the service we deliver and to look for patterns where we can make improvements. With our befrienders, in a lot of cases, we're the first step for them returning back to work, especially after a long period of being away due to a mental health condition. The befriending service, we offer flexible hours. We fit around other commitments such as therapy, training, job interviews, etc. This helps our befrienders build confidence in their work in a supportive environment where they can ask for help without fear of being judged or marginalised. We support and coach our befrienders if they require any advice for CVs, interviews, job applications, for other roles. And we always provide a nice detailed reference where requested. We host regular team meetings with the befrienders to foster that team sort of environment, as mentioned earlier. And any issues they may sort of be facing, we can discuss together in an open forum. We also use these meetings to sort of shape and plan for the future. We review our procedures and we grow as a team within that group environment. We've got just a recent example of that. We launched like a secure web page so they can upload their weekly call logs because they all complain about the old way of filling out forms and emailing them in, and then it was just no fun for anyone involved, including us in the office. So yeah, we've streamlined that and they all do it perfectly now with no problems. So yeah, we've secured funding for the foreseeable future, and we're carrying out a QA project where to see where we can develop more senior befriendees to train and mentor new starters. We've added an element to our training to help befrienders increase call times and to extend those calls where the service users are a bit kind of nervous and sort of with low levels of trust when they first start their calls. And this sort of ultimately helps the service user get more out of it. The more they say, the more they engage, the more rapport they build, and then hopefully that then equates to a better experience of the service and then more confidence as we go ahead. And as we expand for the future, we've sort of outlined and drafted some plans to change our management structure with sort of new lead and admin roles. We've written operation manuals for each role so we continue to operate if a member of our staff gets abducted by aliens in the night. We are also developing training to better inform our befriendees around suicide awareness, refugees and asylum seeker issues. So yeah, I mean, I just want to end by saying that I think it'd be very easy for a lot of care services to sort of shut down when the rest of the country did. And I think sort of having the befriending service is really another example of the results that ELFT has achieved by having service users at the heart of what we do. So yeah, thank you very much for listening.
So you said you have funding. What is the funding for? What's the funding paid?
So we were initially as a crisis, a COVID response. So we had some funding for that initially. And now we've changed the way it's funded and we've secured funding to have it as a service in its own right. So we're no longer a COVID response.
Who gets paid?
So the service users are all paid. They're paid through ELF's reward and recognition program. So yeah, they're paid for their calls, they're paid for the meetings they attend and kind of anything that they input into, because we're paying for that expertise by experience. So yeah.
So that's interesting because it kind of connects with one of Stefan's earlier slides. Where does it sit then? Are these kind of sort of peer support workers? Are they you know, are they professionals? Are they kind of, so I think it's kind of a blurred situation to certain.
Yeah, so it's I would say service users in the mid to end of their recovery period, they're looking to get back into work, to give something back. And it's, yeah, that's their sort of first step on the ladder. And then they build their confidence. And then in theory, then I would hand over to peer support. They could get a more involved role, even like a full-time role or maybe part-time, depending on how many hours they want to do. And we have some befriendees who have completed their time with us, and they would then like to become befrienders. So we've had 3 so far that have gone from befriendee to befriender. So, yeah.
When we did the research, there was a real volunteer befriending scheme.
So we don't use volunteers.
Has that gone? Does that exist anymore?
No, we don't use volunteers. So we started off with.
Is it just a general that there's no volunteer befriending scheme in the whole trust?
No. So we started with staff, volunteers, and service users, but we found that we got the best response from service users. So we were completely service user led. Sorry, there was a hand up.
Yes, Ian.
Thank you. Yeah, I thought it was really interesting afternoon and really well linked presentations. And it just struck me when we talk about, do you need the evidence? Do you need to do the trials for these? And I think that, there's a lot to be said for just treating people right, isn't there? And all the benefits that brings. And I work with people with intellectual disability, and we've certainly learned this with challenging behavior, and just having that sort of holistic care and supporting people right and listening to what people want and going with their agenda pays such enormous dividends. And then what's the role of the clinician? And part of the role of the clinician is actually to say, no, the answer isn't medication. The answer is actually these much wider things and getting the right support and all that. So yeah, thanks very much for everyone's presentation. I thought they were all really good. Thank you.
Thank you, Ian. I think I also find this question rather important, even though it's a challenging one in terms of, do we need an evidence to put money behind? How does that, for example, relate to social services? Is there evidence really that housing, for example, needs to be paid for? Because it's such a common sense issue, isn't it? Can I ask Stefan now to join us a bit? We just have a last 5 minutes, a bit of a exchange around co-production. Where do we go from here? What kind of sort of tickles your interest? Any other comments, questions from here?
I just say I find it disappointing that the trust has given up on the link with real volunteers in the community, because that is something that is a different quality.
We haven't given up. So you asked about volunteer befriending. Yeah. I've still got a volunteer coordinator. So we're doing volunteering in its
What do the volunteers do?
Well, they can do everything from going on wards, delivering groups to sort of meet and greet. So I've got that. Don't worry, I've still got it.
So I find it very encouraging that the trust is continuing with.
The only difference I wanted to make with befriending, I think that from my point of view should be paid.
That's then not befriending. No, none of my friends pays me.
You need to get better friends.
That's the interesting challenge. Can I bring in some other people? Yes, please.
Sorry, just to respond to Professor Fried. So what was your reasoning behind thinking it's disappointing that they don't have volunteers? Because I was just thinking in terms of, I think sort of peer support and befriending, people kind of give up their time and energy and expertise. I think sort of having some kind of financial recognition of that seems important. So I was just interested and curious as to why you felt it disappointing not having volunteers, if they're choosing to pay them instead.
What are you disappointed about? What's the point?
Yeah, I think the point, as I said, that we complain about the community of being that they're stigmatizing and all that, but that we don't tap in the enormous support that there is for mentally ill people. More support, maybe more naive, than is provided by psychiatrists. And I think community care requires a community that cares. And we can't just ourselves, service users, I say patient with patient, and we need to reach out. If we want to tap into the resources that are out there in the community, then we need to reach out. We can't just stay with ourselves. And I think it's disappointing if we don't tap into that. These young students, okay, many didn't do it properly, many left, but those young students, they voluntarily gave up their free time.
I mean, can I quickly respond to that? Because I think I probably have a different view. I think traditionally volunteering's been quite a middle class occupation. I think we're dealing with areas of extreme deprivation and poverty. And I think if we can, alongside this journey, create possibilities for people to earn, to think about their vocational future and their employment future, which volunteering can do. But a lot of the people that we are working with, that money that comes with this is very important for self-esteem as well as. We still do the volunteering, we see that as very important. But I think this notion that everything can be potentially a volunteer is...
Not everything, but there are volunteers and not tapping into. I think it's disappointing. And I think it's a bit discriminating. Why is it wrong if a middle-class person befriends one of our patients? I mean, let's not go into that. I think we're all human beings.
Nothing to go into that.
So we're all human beings. If a patient is ecstatic about someone else doing the first degree, what's wrong with that?
Can I just
respond as well?
just briefly, because I've got another person who would come in.
I'd just like to say that I think that in many ways Paul's quite right there, and it's much like the big idea that David Cameron had about society and provision in society, and that volunteers should do everything, that charity should do everything, without recognising the purpose of that. It was almost utilitarian in its approach. Thank you very much.
Nobody said everything.
Yeah.
Just a single volunteer with a single patient would already be a beginning.
So we need both, please.
Before we start a revolution.
Hello. My question is about using service users to support other service users, especially in services that they have access and might want to access again in the future, so like their own services, and whether there's a danger that it's harder for those service users who are working as, say, peer support workers to then actually access support from the teams that they're now embedded in.
I mean, what we've got is just, I think, quite a sensible approach to that. So, you know, we've got many people with lived experience in many different professions, not just the defined professions that we've talked about today, that at times may need to access support from within the service. So the common sense approach is if you want to receive services in the borough that you're in, you can. If you want to receive them from a neighbouring one, you can. If you're in East London and want to receive them from Beds and Luton, vice versa, you can. But also if you want to receive them outside, you can. I think just having, what we didn't want to do was write a policy for that, because that just would be ultra confusing. Just have a common sense approach to it where we can talk about it and figure out what's best. And we wouldn't be having this discussion if we were talking about physical conditions. We'd just say that's fine.
I think it's a double-edged sword. I think there are potential risks and can be really complicated, and there have been situations where it has been. It can also be so much more powerful if you can say, I was a patient on this ward, and it has an extra kind of valency to it. And in Uganda, where there are very sparse services, everybody has to work within the system that they might have been admitted to and might get admitted to again. And so you could see that it could work, that it was possible. And so I think you're right to give that option to the service users themselves about where they would feel comfortable, but also to plan for it and think about it. If we were going to admit our colleague to our ward, would we be able to still function as a system to be able to do that? And if not, is there something about the way that we're delivering services that we need to adapt to make that possible? It may be for their dignity and for their privacy, they want to go and receive that elsewhere, and that's fine. But we miss out on the possibility of improving our services for our colleagues, for our patients, if we split that off all the time.
Okay, one last question comes from our virtual audience. Befriending is a good service, but I'm just concerned how it will be regulated in managing the vulnerability of service users. Would you like to take that?
So we have a number of different things in place. We have a lone working policy. We have we have some things in place to protect both sides. So we have, nobody is referred to us without having a responsible clinician attached. So if there's any safeguarding issues, any doubts, anything that's just sort of sticking in the befriender's mind, that's immediately escalated to us. Then that goes through to the responsible clinician, and then they can address that from a clinical standpoint. And then from the befriender's point of view, we have the lone working policy. Again, there's we've got an open forum where we discuss things, and they can also contact us if they are having any issues, and then we can use our support system and get them some help and care there if they need it. They're available to take a break at any time. If they need time away for anything, for therapies, etc., then we facilitate that.
Can I just add, I mean, we had an example 2 weeks ago where there was a concern raised, and as we're a non-clinical service, we took it to the Chief Medical Officer to get an opinion on it, to get some advice. So, it is about getting the right advice when needed.
Okay, well, here's another example as to where the boundaries begin to really blur to an extent that it might be really quite challenging. Anyway, the challenges are.
I'll say that challenging in a good way.
Yeah.
Well, I mean, the boundary would be, we'll sit there and talk about, how you're feeling about things, etc. We wouldn't then advise you should be doing this, you should take this medication, you should do that. That's where the clinical line would then sort of be. That's one of our very, very strict, rigid boundaries. So, yeah.
Right, I think we have to come to an end now. Thank you very much for coming. The audience really made it really today to bring our kind of lives to life. And we will do it again actually in July. Thank you very much. Thank you.